On August 15th, 2024, CMS announced prices for the first 10 drugs subject to price negotiation by Medicare under the Inflation Reduction Act. The news has prompted questions about the success of the negotiations, including whether they'll generate savings for the federal government, bring U.S. prices in line with those in other high-income countries, and lower costs for patients. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Benjamin Rome, a physician and health policy researcher at Brigham and Women's Hospital and an assistant professor of medicine at Harvard Medical School. Dr. Rome has co-authored a perspective article about measuring the success of Medicare's first round of drug price negotiation. Dr. Rome, what types of drugs did CMS select for this initial round, and what do we know about how it made those decisions?
What we know is that Medicare selected 10 drugs for this first round of negotiation, and those drugs include products that treat diabetes, cardiovascular disease, cancer, among other conditions. Now, CMS doesn't have a ton of flexibility about selecting drugs. When Congress passed the Inflation Reduction Act, they gave very explicit instructions for how CMS was going to select the drugs for negotiation. So the list of drugs, although was sort of announced a year ago, was not terribly surprising in the sense that many of us could have predicted exactly which drugs, or at least many of the drugs that were on this list.
And then how much do we know about how CMS arrived at the final prices and the factors that may have influenced the negotiations over those prices?
We don't have a lot of insight directly from CMS so far about how the process worked. We will get some more information because they have to release summaries of how they did the negotiation by March of 2025. But what we do know is how the process worked, and at least how CMS laid out how it interpreted many aspects of the law. We know that there was a back and forth negotiation between CMS and the drug manufacturers, where CMS offered an initial price. The manufacturer was able to counter that offer if they didn't like that initial offer. And then there was a back and forth set of meetings before CMS issued its final offer. And in terms of the factors that CMS considered, there were a number of factors that Congress required them to consider. And those included some that were provided by the manufacturer, like, for example, how much research and development costs the company spent on developing the drug, but also some factors like, for example, how many therapeutic alternatives the drug has. What are those therapeutic alternatives? What are their prices? And does the drug that they're negotiating work better? Is it safer, more effective than those products? And based on what we see in the guidance from CMS, those latter factors around therapeutic alternatives and the prices of other treatments were probably some of the most influential in negotiating the first round of prices.
So CMS estimated that the government would have saved $6 billion in 2023 had these negotiated prices been in effect. But you say in your perspective article that the savings might ultimately be less than that estimate. Why is that?
CMS announced the $6 billion figure when it announced these first 10 drug prices. And what that figure represents is a comparison of the negotiated prices for these 10 drugs to the net prices that Medicare is already paying. And that includes rebates that are negotiated by Part D plans, so private Part D plans that carry out the Medicare prescription drug coverage program. So it's important to know that over the last 20 years, even though Medicare has not been negotiating for drug prices, the private companies that carry out Medicare Part D have been allowed to negotiate, and in some cases do negotiate rebates on those drugs. In terms of why that $6 billion might be a little bit of an overestimate, some of the products that are selected on this first list are quite old, and a few of them may actually face generic or biosimilar competition in the next couple of years, even before these prices go into effect in 2026. And that will probably reduce the savings from the negotiated prices because competition from generic and biosimilars will bring down prices anyway. That's a problem that's very specific to the very beginning part of this law, where there are right now dozens, lots of drugs that are eligible for negotiation. Some of them are quite old. But in future years, once Medicare has gotten through that list of older drugs, it's likely that they'll be selecting drugs earlier. Right now, they're prohibited from looking at drugs or negotiating drugs that are under 7 years old. And so basically, once drugs hit that benchmark, it's more likely that they'll be selected.
In your article, you also compare negotiated Medicare prices with those in other high-income countries. Why are most of the prices still substantially higher than the prices abroad?
This has to do with the process that CMS is carrying out to do the negotiation. And as I mentioned, although CMS is considering therapeutic alternatives and prices of other products, they're not doing a formal cost effectiveness analysis. They're not looking at comparative effectiveness data in a rigorous, standardized way like many other countries do. Most other countries besides the United States have a health technology assessment process for all new drugs. And that means that they do that sort of comparative effectiveness and cost effectiveness assessment when new drugs come to the market, and then they negotiate prices centrally based on that. Now, CMS is waiting a period of time after the drugs have come to the market, and they're also not doing that sort of more structured formal process. And instead, they're taking in a lot of data and making a qualitative assessment before doing that negotiation. So one of the differences that our article raises between what Medicare is doing and what other countries are doing suggests that maybe the US and Medicare could negotiate better if it had a more rigorous, standardized process. And that could be something that could be added in the future to make this process more transparent, and could also be used not just by Medicare, but by other private health insurers who negotiate prices in the United States.
How are these price changes going to affect the out-of-pocket costs for Medicare beneficiaries?
Directly, the answer is sometimes the negotiated prices will affect what patients pay, and sometimes they won't. And just to back up, we know that patients' out-of-pocket costs are really important because research that I have done and research that others have done shows that when patients have higher out-of-pocket costs for expensive medicines, they are less likely to adhere to the medicines and can have worse clinical outcomes. So it is important that out-of-pocket costs go down. Now, some of the drugs on the list of these first 10 drugs, many of the patients in Medicare pay a copayment or a flat rate, maybe $20 a month or $40 a month. And in those cases, it's unlikely that their out-of-pocket costs will be directly affected by the negotiated price. But for some of the drugs that are deemed specialty drugs, like those that treat cancer or inflammatory conditions, it's possible that many patients in Medicare are paying a coinsurance, which is like percentage of the drug's cost. And those coinsurance rates will now be based on the negotiated price rather than the manufacturer's list price. So those patients might see out-of-pocket costs go down. The bigger issue around out-of-pocket costs is going to be more directly affected by a separate part of the Inflation Reduction Act. And that's that as of January 2025, there's a $2,000 out-of-pocket limit going into effect for all patients with Medicare prescription drug coverage. And that policy was also part of the Inflation Reduction Act and is mostly paid for by the savings from negotiation under this part of the law. So patients who take expensive brand name drugs, including the 10 on the list, are likely to see their out-of-pocket costs go down next year in 2025 in response to that $2,000 limit.
The next 15 drugs subject to price negotiation are going to be announced by February 2025. What are you expecting from that next round, both in terms of the types of drugs that they're going to select and the negotiated prices?
We don't know exactly which drugs are going to be on the list for the next round of negotiation, but some researchers and other folks in the industry have made guesses. And one of the big classes of drugs that we expect to make the list this next time around are the GLP-1 receptor agonists, so particularly semaglutide or Ozempic or Wegovy. So that might be on the list for the next round. The list is expanding to 15 drugs. It's still focused on drugs that are covered by Medicare Part D, so retail drugs. In the following year, drugs that are infusions, injections paid under Medicare Part B will be eligible for negotiation too. Now, the negotiation process is going to be largely similar. It starts, as you mentioned, in February of 2025 and will extend through November. And then we'll learn the prices for those next 15 drugs. And CMS did make some tweaks to the process, but largely, I think what we were going to see is a very similar process to what we saw for these first 10 drugs.
Finally, two-part question. What steps could Congress or the next administration take to increase the savings that are associated with this drug price negotiation? And given the next administration, do you think that the program is going to survive at all?
I think under the second Trump administration, it's hard to know exactly what's going to happen. Initially, during the first Trump administration, President Trump made several comments and also some policies that really pushed towards aggressive negotiation or policies that would have lowered prescription drug costs. For example, tying the prices in the United States to prices in other countries. That was called the most favored nations policy. But recently, President Trump has rescinded some of those policies, so it's a little bit less clear exactly where things are going to go. And it's possible that Republicans in Congress and the president will try to repeal some parts of the Inflation Reduction Act, including these price negotiation provisions. They might face criticism for doing so, though, because price negotiation is very popular, both among Republicans and Democrats in the United States. People generally are very concerned about high drug costs, and they want the government to negotiate on their behalf. Now, if Republicans were to try to repeal the price negotiation provisions, it would also be quite costly in terms of losing those savings that are already going to be in effect. So the Congressional Budget Office estimated when the law was passed that price negotiation would save the government $100 billion over the first several years of the program. And so taking away those savings would be problematic.
Thank you, Dr. Rome.